If you're building your ABA company and you're tired of guessing, this is for you. We built the BACB blueprint to give you real structure, systems, and support without the fluff. Details are in the description.
Welcome, everyone. Another live stream. Today, we're going to talk about compliance, your supervision logs, and making sure that they actually pass audits. We're always talking about being audit ready. And today, Jamila, Agbloe, and Rosa, Castellanos, they're going to talk to us about how to make sure that you are ready for an audit with your supervision logs. Ladies, welcome.
Thank you for having me. Yeah, I'm super excited, and hopefully this would help a lot of different facilities, but especially the ABA providers. We do have some tools that we would like to share with you guys, and so if that's okay, we would like to just follow the presentation, the PowerPoint that we created for you. Jamila was helping me a lot with this, so kudos and credit to her 100%.
Thank you.
I'll start a little bit with the compliance portion. That's because it's a very important subject, and a lot of facilities, sometimes they forget that compliance, it's out there, and we do have to follow handbooks and regulations, policy and procedures. And then after I do give you my presentation, then Jamila is going to go more into the actual medical billing process and the audits in regards to the medical billing. So one of the things that I wanted to kind of like remind or for you guys to remember is that Medicaid or Medicare are not the only ones doing internal reviews or audits. It's private payers do it too, including the behavioral health audits. However, when it comes to ABA, one of the things that I have been seeing a lot is that there is a handbook, the BCBA handbook and the BCABA handbook. The BCBA does have regulations, and then ACA, the behavioral analysis coverage handbook, refers the supervision section on section 4.2. It refers to the supervision as they refer the provider back to the BCBA handbook. So it means that you have to go back to the handbook and follow those guidelines that you have there. That's because the actual ACA manual or handbook is not 100% specific when it comes to supervision logs. With that being said, then I did, I wish I could, and I think we're going to be able to give this PowerPoint to you guys so you can review it later. I believe so. But then let's go ahead and move on to the actual supervision requirements. So when it comes to requirements itself, I just wanted to give a reminder of the little points, certain points that we see a lot when we do audits and when we actually are looking for the supervision logs. That is the date, start time, and end time, the format, whether it was in person or telehealth, the field work type, the individual or group supervision, if it was restricted or unrestricted activities, the summary of supervision sessions, and indications of whether you were doing observations. So there's a lot of things when it comes to the logs and to the medical records itself. I always say this, if you see something, say something. If you see it and it's wrong, please go ahead and make sure that your medical records are actually reflecting everything that you're doing, including those supervision logs. I will give at the end of this presentation a format or an example of how a supervision log should be or should look like. It's just an example. And I would also provide an audit tool checklist for those facilities that would like to follow the checklist. I think it's very, very interesting and complete, and it would help you to kind of guide you through all this documentations that you should have. Another thing that I have here is the responsibility of a supervisor. So remember, and I get all these points. I'm not just coming up with this. These are things that you have under your BCBA handbook. Remember that as a supervisor, you are responsible for whoever you are supervising. So when it comes to, for example, the RBTAs or the BCBAs, it's not just about meeting a 5% supervision. It's about making sure that they are also following the code of conducts, that they're actually writing those medical records the right way, that the medical records is matching the billing that you're doing, that the supervision logs are complete. And if you see something wrong within those RBTA's notes or whatever it is, you have to come forward and say something, because then you get into an audit, it delays the payments. You get into a prepayment review, which could actually prevent you from any reimbursement. Another thing that I have is just reminders of the notice of alleged violation against the RBTAs or supervisee, whoever you're supervising. So there is, within the handbook, there are some forms that you need to actually fill out in case that there's something that you need to report. So it's not just sitting there and rendering services and supervising services. If there's employees that are under you or RBTs that are under you are not following regulations, and let's say, for example, there might be committing fraud with interviews, you are entitled and you have to actually report those violations to the BCBA. When they do come back to do audits and they actually request for the logs, they will request, and they reserve the right to request for a lot of these things. For example, whether or not you have, created some type of logs or notice of allegations on whether or not you have reported or internally reported or self-reported any type of violations. That's part of the audits that they do. One of the things I wanted to, so this is part of my slide, which is number 5. I'm gonna give all this to everyone. But one of the things that I wanted to kind of like remind, it's a reminder to you guys, is that, the planning when it comes to transition from those supervising services, or like, let's say that you're no longer going to supervise that RBTA or BCBA, remember that there has to be certain things that the handbook requires, and I added them there as well. It creates a more a smooth process, so you don't find yourself impacted in a negative way when it comes to actually just discontinuing the supervision for for those services. And then this one is super interesting because I gave a little list of what the auditors look for when they're doing reviews of the logs. So it is, again, the modeling, the feedback, the service setting, the signatures of both the supervisor and the RBTA or BCABA, and then how the auditors are going to compare those logs, against the claim submitted. I am providing a little workflow of like what you guys can do. And like I said here, you can use a standardized supervision log and complete it immediately after the sessions. Keep your logs organized and secure. Schedule recurring supervision in advance. And this is a non-negotiable. Like, you have to schedule those supervisions and try not to forget to actually like complete every documentation. Involved your RBTAs into the process of, like signing and reviewing the logs. And then obviously I'm making sure that everything matches what you're billing. So again, being audit ready is super important. Every time we review medical records, a lot of things that we see are preventable. It's just mainly things that facilities are forgetting to actually add into the medical records. Not necessarily that the services were not rendered, but it wasn't documented. So if you spot it, stop it. And if you see it, and it's wrong, say something, come forward and try to avoid those negative outcomes because the medical record didn't have enough documentations. That is basically what I have. I do wanted to show you, this is just an example, and I think it was super interesting. This is just an example of a behavior analysis intervention supervision log. I can provide this example. Again, you would have to get this information and apply it to your facility based on what you how you work within your organization. But I think it's great because it helps a lot with like keeping everything on track. Then what I do found, which was it's actually very helpful, is that this plan itself provides an ABA audit checklist. This is public. It's not that I took something from like the health planner, and this is actually out there within the health plan, the handbooks, policy procedures. They give this to providers. So it's something that you can also look up. The ABA audit checklist. What is it that they look for? What is it that, and the reason why I'm bringing this up is because within the Facebook page that we have, I see a lot of people asking questions about, oh, what is it that they look for every time they do audits or whatever. I've seen that a lot. So I decided to bring this to you guys. This is a checklist of everything that the health plan looks for when they do a clinical, mainly a clinical audit, not necessarily a financial audit. So you have two different audits. You have clinical and also financials, or special investigations audits, but this is mainly clinical. This is like everything they're expecting the facilities to have within the medical records or the policy procedures and manuals when it comes to compliance. Down here, you can see the audit tools. This audit tools is super interesting because it gives you a lot of different questions, and you can do yes, no, or not applicable. And actually, you can use this audit tools internally within your own facility and do internal audits and make sure that you're following regulations. This is exactly what they're looking for you to do. Like go ahead and recreate this for you and make sure that you're following all these things. I am more than happy to provide all this for you, especially also your handbooks. If you don't have your own BCBA handbooks or your BCABA handbooks, then I'll be more than happy to send this over. But for now, I just wanted to give everyone these tools and kind of like a little reminder of all the things that you should have when it comes to supervision and your medical records.
Okay, great. So I'm gonna go into the navigating billing practices in ABA therapy. And it's a payer-centric approach for the BCBAs and RBTs. And so it's really just pretty much focusing on the payer policies and guidelines. Every payer has their own individual policies or guidelines. Once you get into the billing portion of your practice, submitting the claims, getting denials, that's when you'll really start to understand the differences. And I can tell you about it, but until you have the actual lived experience and that real world example to call upon, it's not going to really make sense because, as I said previously, every payer has their own policy. So it's very much would be in your best interest to understand their guidelines, how they pay, what services are covered, how they're covered, the settings they're covered, what diagnosis is needed. And all that goes into proving medical necessity, but we'll get into that later. So for the most part, the primary thing is understanding that the policies are different. Now, what you can do is when you understand which policies you're going to have, the patients that have the most information with whatever policy they're choosing. One tip that I can recommend is when you contact them, ask them, do you follow Medicare guidelines? when it comes to a specific service or procedure that you're doing. Sometimes they may follow Medicare guidelines. And if you already know what Medicare guidelines are for that specific procedure or purpose or service, then that will pretty much cut down on you having to go and look for information to understand how it's fully covered. Another thing is the uniform billing approach. It does not exist. So you will have to understand their requirements. Get familiar with your provider portal. A lot of the information is readily available. You just have to take the time and read it, know how to navigate each payer's website, and find all that information. Now, you can contact the payers directly. However, you are going to spend a lot of time on the phone. They like to put you on hold. A lot of times you will hear, "We can't tell you how to bill." And they cannot tell you how to bill because, of course, they are trying to make sure that you understand and you're submitting the claims fully, your documentation fully supports it. And they are trusting that you already have people in place at your practice that are the experts on that. And so the common line you will hear is, "We can't tell you how to bill." And so you may get a representative on the line who will try to indirectly lead you to where you can find the information. They'll tell you the policy is located under, or if it's Medicare, they'll tell you it came out with this statute on this date, or it's regarding this LCD or NCD. So if you find one of those people who will give you that information, just try to get all your questions answered, because you will be on the phone a lot of times and it is very time consuming. And I know when you're trying to care for your patients, the last thing you want to do is to constantly have to be on the phone contacting the payers to find out why something is not paying. Now, the RBT services, they're often considered an integral part of the overall treatment plan. And they are seen and directed by the BCBA, which I'm sure a lot of you already know this. And many providers, or payers rather, they don't differentiate between services rendered directly by an RBT and those provided by a supervising BCBA. And again, that's many of them, but just to be on the safe side, become extremely familiar with your payer policies and know which ones will do that. Because the last thing you want to do is to get in the habit of assuming that, well, I've had all these policies pay from these different insurers. Let me assume that they'll pay across the board. And then you'll start, accepting a patient who has a specific policy that it doesn't cover the way all the others do. And then you've provided the service. Now you're not able to get paid for it. And we definitely want to be able to get paid for the services that we are providing. So just always be aware. And when you start with your credentialing process and the contracts, whoever is doing that for you, they can definitely help you understand more of what is involved in your payer policy. And they can also ask for some provisions in your contract that maybe, they normally wouldn't do, but because of the area you're in or your location, they may be able to put in a specific caveat for you. Because I like to say, a closed mouth doesn't get fed. So if you don't ask, the answer will always be no, because that's all they can say is no. So you can be very proactive in your contracts and finding out, how far can I push them to cover some things in a different way. And also, when you do have your services, RBT services that are considered a part of the treatment plan, they are typically submitted under the supervising BCBA's provider information, including direct therapy by the RBT. And exceptions exist. Some payers like TRICARE, they require them to be billed separately. And that'll often mean you'll have to include a specific modifier for those codes. And so that is case in point, what I just spoke about is not across the board. So you really do have to know every specific payer policy. Now, the decision to bill as a BCBA or RBT, that again, is entirely on payer requirements. So all this goes back to understanding every individual payer policy. There's no way around it. So that would be something that you would really, really need to just become extremely familiar with, very familiar, because once you start submitting claims and you start to get these denials, and they're going to refer you to their payer policy. And if you've never read it completely, you don't understand it, it's going to feel like, you know, they're speaking another language because they expect you to understand that. And as I said before, they will hit you with the, we cannot tell you how to bill. So there's no way around getting past not thoroughly reviewing each payer policy. So let's go to the next slide. Now, the thing with each individual payer policy, they may all have different payer-specific determinations of what constitutes medical necessity. Now, with medical necessity, what it means is, are you providing a service that is medically necessary for the patient? And how are you proving medical necessity? How are you documenting your treatment plan to show that this was medically necessary? And so each payer, they establish their own guidelines and standards for medical necessity. And it often includes a lot of the local federal laws and regulations. And they include interqual behavior health medical necessity criteria and the MCG health behavior healthcare guidelines, formerly Milliman. So, and then also you'll need to make sure that you understand every state specific regulation. And that's more of what Rosa gets into as far as compliance goes, because compliance is a part of medical necessity. When we start to talk about the federal and local regulations, that is a huge part of proving medical necessity. And so when you want to document medical necessity, it's crucial to understand what each payer's requirements are. Some will want a clear understanding of the activities that are linking this patient to have significant behavioral goals or skills that they need to work on. Some may require you to give a specific diagnosis depending on the type of treatment you're giving. So you could say autism, but then some will want, you know, to go more into detail. They like to see, what have you tried? Have you did a case of where you tried this service and that didn't work? Now you're moving up to a more robust service plan or treatment plan for the patient. I know with Medicare and some other provider or payers that I've looked at, they will see if you actually tried a, I wouldn't say less invasive, but a less complicated form of therapy, something that doesn't require, maybe let's say for this example, the patient has come in and you are starting them off at maybe 2 hours of therapy, where why did you skip straight to the 2 hours instead of an hour or 30 minutes? What required you to go above and beyond what is normally how these patients are seen? And so you would have to prove through your notes the justification for that. And so whether that includes what you did previously, why it didn't work, how it didn't work, medications you've tried that you didn't, that didn't work or give you the results you wanted, you have to actually show what has been done to necessitate this new in-depth treatment. And so all of that is part of proving medical necessity, which again, robust documentation is required. So I think in one of Rosa's PowerPoint slides, if you don't document it, it doesn't happen. So payers are not going to assume that something happened. They need to see specifically exactly what you did. So the goal is for them to look at your documentation, your treatment plan, everything that happened in that session, and be able to visualize what went on. So they're not going to assume that you gave them goals to work on. They have to know exactly what specific goal did you tell them to work on? How often did you tell them to do that goal? What is the goal of them doing this exercise? What do you wish to accomplish? How is it going to improve them? You have to know all of that stuff. And they want to be able to see that in your documentation. And that's a huge part, if not the biggest component of documentation and medical necessity, is being able to show your work. So now these are some strategies for avoiding ABA claim rejections. And here I'll go into the difference between a rejection and a denial. So the rejection is what happens when you submit through your clearinghouse and it does not reach the insurance company. And so it's rejected before it even gets there. And a lot of the reasons for a rejection could be the insurance information is wrong, the date of birth is wrong, a misspelling in the patient's name. Another thing could be you don't have the correct address that's on the insurance card, or the beneficiary is not correct. So many things. And that will, of course, delay your payment because it's delaying the claim actually getting to the insurance company. And so you can address these and actually reduce a lot of these errors just by making sure your front end staff or whoever is doing your billing or submitting to insurances understand what to check for, understand to pay attention to these fine details, because it may seem like something small, but all of this is part of the insurances knowing that people aren't committing insurance fraud, they have the correct patient, everything works smoothly. And so, and then also just having something in place to track it and someone there to work the rejected claims to find out what went wrong and to get those out as soon as possible. Because you also have to keep in mind, a lot of these insurance companies have timely filing limits, and you definitely don't want to miss out on that, because that is when, if you don't file in the correct time frame, it's over with. You don't get paid. It's you just can't submit the claim anymore. They're not going to pay it. Now, for the denials, this is when the claim has actually gone through the clearinghouse. It's been submitted to the insurance company. They've looked at it and they are making the decision whether they want to pay it or not. And so when they deny it, they're saying to you, this claim has been denied, and they will give you a reason why the claim has been denied. And this is where you would need to have a good understanding of the codes used on the EOB. And so some of the reasons for denial, it could be medical necessity. It could be improper use of a modifier, or a modifier was needed and it wasn't used, or it could be timely filing limit was reached. You didn't file the claim within that time period from the date of service. It could be it's not covered. You didn't understand the payer policy and it's not even a service that they cover. All of this will be communicated to you in the EOB, and it's usually a specific set of codes. They'll give you a tiny little definition. Some of it is you'll look at it and be able to understand what it means. And some of it is kind of like, I don't know what this means. I have to give them a call, or, someone who knows what's going on can decipher that for you. And another thing is, if you are having issues with denials and you've done everything you can do, you can reach out and go a step further. And that is to contact your local, your state's commissioner, insurance commissioner, and they can go to bat for you. That's the state insurance commissioner's office. And what they'll do, they kind of work also to make sure fraud and waste and abuse is not going on. They'll get to the bottom of it and make sure they're actually going by the local and state federal guidelines for the laws and regulations that insurance companies have to abide by. And another thing I wanted to talk about too on this slide. Now, in the event that the claim is denied and you correct the claim, whether you add the missing modifier or you have documentation that shows what you did is in fact true and it should not have been denied and it was denied in error, you can submit a corrected claim, or if the claim is correct and you think it should have been paid, that's when you would appeal it. Now, to appeal it, and again, this is payer specific. Some insurance companies will allow you to appeal as many times as you like. You can submit corrected claims as often as you want. And there are those payers who will only allow you to submit as many corrected claims as you want. But once you decide to appeal it, they'll only give you one time to do that. And depending on how that appeal goes, it's one and done. So if you shoot your shot with that appeal and it still doesn't work out, or you didn't have all the correct information to support it, it's over with. The claim is done. You won't get paid. And that's the end of that life cycle for that claim. However, if you do decide, I follow the payer policies, I have everything in order, and you submit your appeal, and they will pay it, because some insurance companies, they do make mistakes. They have humans working and looking at these claims. That's how I know Rosa. I worked as an auditor, and that was my job, to make sure the documentation supported the codes that were billed. And so there is a live person who actually goes through. And so it could be something as small as, with healthcare, we all know things are constantly changing. So it could be a code that was denied, that the person who's looking at it didn't know, wasn't updated, is not up to date on the education portion of their position, or it's just something they're not aware of. And it does happen. So make sure you are actively working your denials, working your appeals, and getting your claims corrected, because so many providers will leave money on the table because they just don't understand the process of how to get the claim paid. And so that goes back to making sure you have the proper staff in place that can help you do all of these things. Now, these are some strategies for avoiding claim rejections. Ensure your staff is trained correctly on the procedures for electronic or paper submissions. Establish a protocol to double check all of your patients' demographic information. Also, do insurance verification. Make sure that the patient does have proper insurance coverage. It could have lapsed, something could have changed, a last name change, anything could change that would throw it off, that, the average patient wouldn't understand would cause something to be denied. Also, keep copies of the insurance cards of your patients. That way, if there is something that was typed in error, you can go back and verify exactly what it should be without having to get a hold of the patient and stall your claim from being submitted. And also, you can submit or implement a tracking system that lets you know, timeframes and deadlines, and you can stay on top of that. And then to get an automated billing software, it can actually reduce a lot of errors and improve efficiency and increase your revenue cycle, so that you are receiving maximum payment and you get those payments faster. Alrighty. So this is the portion where if anyone has any questions for myself or Rosa, we are more than happy to answer them.
Thank you, ladies. All right. So setting up like kind of that self-audit process, how do you recommend, what is the process for figuring out what you need to do, where you need to check for like what the requirements are, kind of setting yourself up with a schedule and putting together your kind of standard operating procedure for your self-audit process to make sure all this stuff is straight?
Right. So one of the things that I do recommend when you do self-audit is to actually there's a tool, and this is something that I'm going to share with everyone, that you can actually, some questions, it's like an assessment that you would actually ask yourself, and whether or not you are following this assessment. One of the things that I always recommend is to get those contracts that you have with your payers. Let's say that, I don't know, you're contracted with 5 payers, health plans, and get those contracts and review their handbook, their manual, and what are the requirements, and then come up with an assessment plan for yourself, for your facility, and do check mark. Okay, am I satisfying my contract? Am I, following these handbooks? And they do provide information with those handbooks. They provide information of the things that they expect to see within the medical records. That's an easy and straightforward way of doing it. Kind of like, it's instead of like thinking or researching all this, what is it that the payers are looking for when it comes to like medical records, or when it comes to the facility itself. Just go to those contracts and to every single of those handbooks, and see what, based on those codes that you build, the service that you render, then what are the requirements, and do an assessment on yourself. Am I meeting these requirements? And that would be an easy, straightforward way of doing it.
Obviously, we have a lot of people that are running small businesses and doing all the billing themselves and staying on top of it. So what do you suggest for people who don't have the time to sit down and do the self-assessment, but know that they need to get their records straight?
So this self-assessment, you don't have to do it every month or anything like that. I do recommend you to do it once every 6 months, for example. Just do a mini internal audit on your medical billing once every 6 months, and see if there's any discrepancy within the billing, and go ahead and compare it to the medical records and compare it to the manuals. Once a year, payers do tend to update the policy reimbursements, go back to those policy reimbursement once a year. Usually at the beginning of the year, between January and March, they update their policy reimbursements. Go back and check whether anything has changed, and then do your internal audits. You don't have to select a sample of like 200 claims. You can just select maybe 10 claims, but try to like general overall, like include all the CPT codes that you bill, and see, go ahead and select 5 medical records for each one of those CPT codes, and see whether or not your records are supporting the services rendered, whether or not you're following those regulations that the payer wants you to follow. That would be also a good idea. You don't have to do it every month. It might be just something that you do once every 6 months. Do an internal audit just to make sure that you are actually keeping, being on top of everything that you need to, just follow all the regulations that you need to follow.
Is that a process? Is that a service that you offer to come in and do those audits and set up the compliance program?
It is. We do internal audits. Jamila does it too. We both can do it. We do internal audits once every 6 months or once a year, depending on the providers. Every facility is different. Every necessity is different. So we do internal audits. We let them know. We review those records for them, and then we let them know, okay, listen, this is what we're seeing. And then we educate them. This is how you can actually correct yourself. Also, it's very important to know that a lot of times, if there's any discrepancies within the medical billing or the medical records, it is good to do a self-disclosure. I actually tend to advise the provider to go back to the health plan and be like, you know what, we did an internal audit and this is what we found, and go ahead and we overbilled by mistake, and here's the money back. The reason for that is because it creates a good intention. Obviously, one, you're following your contracts by doing internal audits, and two, you are being honest. I don't want you to be afraid and be like, oh my God, but if they're gonna see these mistakes, they can come back and like review everything else. It could happen, but when you actually do it yourself, then it prevents you from bigger problems in the future.
Yeah, I'm sure it's less if you pay, less problem if you find it and you pay than them having to come out and find it.
Exactly. Yeah, because their samples, it's going to be a lot bigger than yours. Obviously, if they start doing them themselves, if you wait for them to knock on the door and do audits on you, then their samples might be a lot bigger than yours, you know.
All right, ladies, thank you very much once again. The self-assessment sheet, and then we'll make sure that we have the ebook in the video description as well. So we'll make sure that we have that in there. So if any of you guys watching want to grab those, help yourselves, and reach out to Rosa and Jamila if you need any help with any of this stuff.
Awesome. Thank you.
Thank you.
Bye, ladies.
Bye,
Thank you.
everyone.
Thanks, everybody.
Bye. All right, bye.
You're already doing the work, investing your time, your energy, and your vision. So let's make it count. Build something that works without breaking you. The EBCBA Blueprint is the way. Get started for free with our foundation course.